Hello, fellow doctors, my colleagues, and students who are trying to prepare for AMC 1. Welcome to another video. This is chapter 13. And in total, I think we have 33 or 36 chapters. If you guys want notes more quickly and you have already gotten your placement letters, you guys are free to join the intensive group on Telegram. You guys can find the links of it in the description. If you guys don't have a placement letter, you guys can still get these resources, all of them for free. And that's the foundation group, and both of the links are in the description below. So just send us a request to join. We'll accept. You guys can have all of those resources for completely free. And today's topic is going to be a very important topic because I've seen at least 2 to 3 questions every single year from the pediatrics section. And in this, in Feb, March recalls, we had 5 to 6 questions. In April, if you recall, we had around 3 to 5, I think, questions on average from this. We'll be going over all of the important topics that they like to test upon. Anything that's missed or that's lacking, you can find them easily in the Telegram group, because those usually are one lines here and there that we like to include in the intensive group. That's better for doctors to revise it 1 to 2 weeks or at least a few weeks before their exam, so it sticks to them better. All right. And now in today's video, we'll be going over the development, the different vaccines, RSV vaccine, the different kinds of seizures, how do you differentiate them, crop, SCFE, infant, UTI, foreign bodies, and hernias. All right. Now to start off with development, in the last in April's recalls, we had patients. What they would be checking on would be the gross motor functions of those patients, and also how many blocks can they stack. Is it 2 blocks, 4 blocks, 8 blocks, make a complete tower? If they can make a complete tower and knock it down, things like these. But for the towers, I've not included them in these because those are new guidelines depending on the month that you take the exam. All right. And it's in the fine motor as well, but just check the Telegram group, because in the Telegram group we usually post videos that are up to date, and that's why I like to date my videos every single time, that what time is it being posted and what are the guidelines for them. All right. Now the important one for 2 months is going to be they can lift their head. All right. And they have cooing and they recognize their mother. 6 months, they sit with support. They have a palm of grasp, and they can transfer one object from the other, and they just babble. 9 months, they can sit independently, pull, and with pulling they can stand. Then they have an inferior pincer grip. Then language mama dada, and they wave a bye bye and peekaboo. 12 months, they walk with support and they have the first steps. Then they have pincer grip, tip to tip. All right. Tip to tip would be this. All right. Then 1 to 3 meaningful words, and they point to objects that they want. Now 15 months, that they can walk independently and they can scribble spontaneously. 4 to 6 words points to body parts, and parallel plays and removes clothing. 18 months, they can run or climb. They can tower 6 cubes. So remember, 18 is 18 is going to be 3 cubes, not 6. They can tower 3 cubes and they can scribble and parallel play, and again they will have temper tantrums. At 2 years, they can tower 6 cubes. They run and kick ball, and they can climb stairs with rails, and 50 plus words and 2-word phrases, and they have a possessiveness about them now. At 3 years, they can start on 1 foot, and they can have a pedal trike. That means they can walk properly. Then they can copy a circle, and they can tower 9 cubes. All right. So 3, 6, and 9. So we're moving up by threes. All right. And 3-word sentences, and they can ask why. They have group plays and dresses with help. Now at 4 years, they can hop and catch ball, and they can copy cross, the plus sign. All right. Now they have 1,000 plus words, and they have stories for them, and they have certain rules, such as they can brush their teeth. At 5 years, they can skip. They have 1 word for more than 5 seconds. They can copy triangles. They can read simple words and dress independently. All right. Fine motor key at dates. All right. Pincer grip, 12 months, tip to tip. Scribbles at 15 months. Copies circle, copies cross, and copies triangle. This was in March. All right. And April, they had cubes. How many cubes can they stack? They gave a month, and that's asked the question that how many cubes can these guys stack. So the immunization schedule is going to be different for ATSI and all the others in the country. All right. At birth, we'll have hepatitis B within 24 hours. 2 for 6 months, we have DT, AP, IPV, HIB, and Hep B, Infandrex, Hexa, and PCV13, which is the rotavirus oral vaccine. 12 months, we'll have MMR, Men, ACWY, and Hep A. 18 months, we have MMRV, varicella included, DTAP and Hep A. 4 years, we have DTAP, IPV, MMR catch-up. Year 7, we have HPV, Gardasil 9 2 doses, and DTPA booster. All right, and year 10 we have men ACWY booster. All right, now the key is going to be MMR first dose is going to be 12 months, varicella is going to be 18 months, HPV is going to be year 7. Rotavirus must start by 14 weeks and 6 days, because if it started later on, as it says, that there's a risk of interception. All right, now moving on to the RSV maternal vaccine. Now the purpose is going to be to protect the neonates from RSV, which is the most common cause of bronchiolitis in infants, and maternal antibodies can cross the placenta. Just remember that. Now the timing is going to be that it's given at 28 to 36 weeks gestation, and it is not given in early pregnancy and not contraindicated in pregnancy. And the vaccine names are Abrysvo, which is Pfizer RSV perfusion F vaccine, and it is TGA approved for maternal use. Then a pregnant woman is going to come at 28 weeks and it's going to ask about RSV protection for a baby. We give a vaccination at 28 to 36 weeks gestation, and we do not wait until morning sickness subsides. All right, and it's not contraindicated and it's not needed. All right, these are the different options that came. All right, now moving on to pediatric emergencies. Febrile seizure, it's pretty simple. The kid is going to have a fever and they suddenly develop a seizure. It's generalized, less than 15 minutes, once in 24 hours. Age is going to be between 6 months and 6 years, and it is not meningitis unless there are additional signs. Management usually is just reassurance. All right, usually because it's benign. Then IV or rectal diazepam if more than 5 minutes. All right, and MSU for UTIs. Then febrile seizure, which is complex, more than 15 minutes, or focal or multiple in 24 hours. For this, we have to get a lumbar puncture done if meningism is present. And in EEG, we check the EEG and we get a neurology involved in this. Now, crop is going to be, this is the most favorite disease AMC loves to ask about, is the patient is going to present with a barking cough, inspiratory stridor, and age is 6 months to 3 years. And most important, steeple sino-chest X-ray. All right, because it's autoimmune mediated, we give them oral dexamethasone. We use corticosteroids, we give them oral dexamethasone, which is single dose, and if it doesn't help, we give them adrenal nebulization if it's moderate to severe. Then epiglottitis, it is toxic. Patient is going to be drooling, and most important is tripod position and thumbprint sign on the x-ray. H influenza type B is the causative agent. We do not examine the throat, we don't do anything, we just stabilize the patient, we calm them down, and we call the ENT. And anesthetic, now the drug of choice for this is IV ceftriaxone, but they don't ask about it. They usually ask what's the next step, which is we call the ENT, and we do nothing. All right, bronchiolitis, it's less than 2 years, RSV, V's plus crackles and tachypnea, and we just give them supportive treatment. Salbutamol is not evidence-based, and O2 if the SpO2 drops below 92%. Then meningococcal disease, in that will have non-blanching rash and meningism. Waterhouse-Friderichsen syndrome. All right, for this we give penicillin IV or IM immediately, and blood culture, then LP. All right, prophylaxis is going to be ciprofloxacin for meningism as well, and for this disease. Now SCFE is seen in obese adolescents between 18 to 16 years. It is referred knee pain, and it's limited internal rotation. We stop weight bearing exercises, we get them an orthopedic referral, and it's in situ pinning. All right, simple. SCFE is the most simple one because we usually get x-rays for that, and we can easily use it SCFE. All right, now infant UTI, the treatment is slightly different than adult UTI because in infants they do not present with typical UTI symptoms. All right, instead they'll have fever, poor feeding, vomiting, irritability, dehydration, and jaundice in neonates. Then we do a dipstick test. We see positive nitrites, leukocytes in infants. Positive nitrites and leukocytes, it means UTI until proven otherwise, and we do not dismiss UA findings because symptoms are non-specific. Now the common causes, the common microorganisms is E. coli and Klebsiella. E. coli is the most common one that they ask about. Diagnosis is going to be midstream urine or MSU, or catheter specimen urine, or CSU for culture, and it's not back specimen because back specimens are usually contaminated. Treatment is going to be oral cephalexin or trimethoprim, so new drugs. cephalexin or trimethoprim for mild moderate, and IV ceftriaxone for severe or septic. Investigation: after first UTI, we check renal tract USS or ultrasound, and to exclude structural anomalies such as vesico-ureteric reflex or renal scarring, then DEMSA scan if it's recurrent. Alright, so the patient that they'll present with is going to be fever, non-specific symptoms. Ultrasound is going to show, urine analysis is going to show nitrites and leukocytes, and most likely is going to be UTI, and it's not just gastroenteritis. We treat and investigate the structural cause. Now, moving on to bilious vomiting. So they've started talking about bilious and non-bilious vomiting. So bilious vomiting is always going to be a surgical emergency in neonates until proven otherwise. So neonates by 7-day-old, surgical emergency. Differential most likely is malrotation with mid-gut volvulus, which is most dangerous because of the volvulus, and then rapid bowel ischemia can occur. Then duodenal atresia, double bubble sign, jejunal atresia, then Hirschsprung's disease, and initial investigation is going to be an X-ray, abdominal X-ray. First step is going to show a double bubble sign. Sign is seen in duodenal atresia, and air in stomach and proximal duodenum. That's where we have a double bubble sign. Definitive investigation for this is going to be an upper GI contrast study. So barium or water soluble for suspected mild rotation, and it shows abnormal positioning of the duodenum jejunum junction. Management: it is going to be none by mouth and IV fluids, NG tube, urgent pediatric surgical reference, LATS procedure for malrotation volvulus. We do not delay because a mid-gut volvulus can cause complete bowel ischemia within hours. Just remember that. Alright, we don't delay. Now moving on to pediatric hernias. This is kind of a new hot topic right now because they want you to differentiate between umbilical hernia, epigastric hernia, inguinal hernia, and strangulated hernia. Alright, now most of the if you're a doctor at this stage, if you've already graduated, you already easily know that you can differentiate these based on the position of that of the hernia. Right now, the only thing the important thing is going to be strangulated hernia and an inguinal hernia. All right, because most of these we refer to the emergency department, and especially for inguinal hernia, because inguinal hernia it can lead to rotation and leading to the parts of the intestine getting cut off, leading to a surgical emergency. So you have to see it from usually case-based question. So does this start with umbilical hernia? It is a protrusion through the umbilical rings, very common in infants, and usually going to resolve by the age of 3 to 4 years. It's soft and easily reducible. All right, soft and reducible usually means it is not an emergency. All right, so again, reassurance, observation if asymptomatic, and we refer to pediatric surgeon if it's persist more than 4 to 5 years, or if it's large, and if it's symptomatic, or if it's incarceration, or we suspect that this could lead to an incarceration. Now, epigastric hernia, it is the protrusion between the linea alba between the umbilicus and the xiphoid process. So if the umbilical hernia is here, the epigastric hernia is going to be more superior to it because it's between the umbilicus and the xiphoid process. It has a small, round, firm mass in midline, and it is usually tender. For this, we refer to pediatric surgeon because most do not resolve spontaneously, and surgical repair is usually recommended. Now, inguinal hernia in infants, it's protrusion through the inguinal canal or the inguinal ring, more common in boys and premature infants, often intermittent. It appears with crying or straining, and there's a risk of incarceration. Routinely, we have elective surgical referral, especially for an unsettled child, because it could mean that there's a possible incarceration. We refer to ED urgently because there's a risk of bowel compromise, and we do not reassure. Same thing for strangulated hernia. It is hard, tender, irreducible. All right, it is irreducible. Important. And it has it's a irreducible hernia with systemic signs such as fever, vomiting, peritonism, and it's an emergency surgery referral. So we just send them to the surgery department. All right, now coming up to the school exclusion criteria. This is just a small summary. We have an amazing chart, amazing diagram in the Telegram group. You guys can check it out for free, and it's one of the best ones to remember because it also has images. So for chickenpox, varicella, we exclude until all blisters have crusted, and all of the immunocompromised contacts, we give them VZIG. All right, measles, 4 days after rash appears, and contacts, we give MMR within 72 hours or IG within 6 days. Pertussis or whooping cough, 21 days if it's untreated, or 5 days after starting antibiotics. Household contacts, we give them azithromycin prophylaxis. Now, this is one of the questions that came in the April recalls. Impetigo, we treat until we exclude until treatment has commenced. And for close contact we have a topical and not for close contact, for the patient we have topical or oral antibiotics. Rubella 4 days from after 4 days after rash. And pregnant contacts we have to get them urgent serology, because it can, it can lead to hydrops fetalis. So it's a very severe condition for rubella. We have to check the serology of the pregnant patient. All right, mumps is going to be 9 days from parotid swelling, and that's about the important ones from the last 3 months. But if you want the full diagram, the full table, just check out the Telegram group. It's there for free. All right, now moving on to the key numbers. Just memorize these are very important, and a lot of the questions will come from them. And that's all for today's video. Hope you guys enjoyed and learned something important for the AMC. If you guys have any questions, leave a comment with your question, and I'll try to respond to it as soon as possible. And right now we'll have videos coming out consistently, and just like the video if you guys enjoy it and find it useful. Again, all the links are in the description. You guys have any problems, any confusions, just drop a comment, and I'll make sure to answer them. All right, bye.